Welcome, good afternoon. My name is Marissa Lozano, and I'm the Director of Community Education with the Muscular Dystrophy Association. We're very glad to have you join us for day 2 of our Myasthenia Gravis virtual learning series. This learning event is part of our larger MDA community education programs, which focus on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming programs. We are recording today's session and we'll be posting it to the website for on-demand viewing at a later date. Please know that all phone lines have been muted, but you can still ask questions. We'll have a Q&A session at the end of each presentation. Simply use the chat feature to type in your questions and they'll be addressed after the presentation. MDA would like to thank our supporters, Alexion, argenx, Genentech, and UCB for supporting today's virtual learning series. For nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through our care center network, and advocating for access and inclusion for the neuromuscular disease community. Our mission is to empower the people we serve to live longer, more independent lives. MDA empowers people living with neuromuscular disease across the country through cutting-edge research, access to top-tier expert medical care, comprehensive resources and education, and advocacy for access, inclusion, and independence. If you haven't done so already, we invite you to join the MDA community by registering with us. Registering is free. Please see the link in the chat for the sign-up form. We'd like to recognize that June is Myasthenia Gravis Awareness Month. MDA is dedicated to supporting the MG community. Over the last 7 decades, MDA has invested $57 million in MG research. We invite you to check out MDA's resources for MG listed on this page. And to learn more about all of our efforts in the myasthenia gravis space, please visit mda.org. MDA is excited to bring you this great lineup of presenters who are here to give us updates and information on MG. Last night or yesterday afternoon, we heard from Dr. Mupidi from Stanford and Dr. Spahn from Stanford. Today, Dr. Jeffrey Rosenfeld from Loma Linda will discuss treatment management to alleviate symptoms of MG. And Dr. Leslie Delfiner will round out the series by sharing special considerations for children with myasthenia gravis. Now it's my pleasure to introduce our first speaker, Dr. Jeffrey Rosenfeld. He is a professor and associate chairman of neurology at Loma Linda University School of Medicine. In addition, Dr. Rosenfeld is director of the neuromuscular ALS programs and medical director of the Center for Restorative Neurology, a unique multidisciplinary program at Loma Linda University Health. Previously, Dr. Rosenfeld has served as professor and chief of neurology for UCSF Fresno, as well as the chairman of neurology at the Carolinas Medical Center. In addition to a long-standing tenure of neurology leadership positions, he has had a focused research interest in myasthenia gravis, as well as ALS and related motor neuron diseases. He has served on the board of trustees for the Myasthenia Gravis Foundation of California for several years, and he has been awarded Neurology Teacher of the Year for 5 years at Loma Linda University. Dr. Rosenfeld has developed unique multidisciplinary clinic models at 3 locations throughout the country. The most recent project included the establishment of the Center for Restorative Neurology at Loma Linda. The program is the only one of this type with full-time dedicated resources to serve the neuromuscular, ALS, and MND community, attracting patients from across the country. Dr. Rosenfeld, thank you so much for being here today, and I will go ahead and turn the time over to you.
All right, thank you very much, Marissa. Welcome to all of you tuning into this. It's really my pleasure to be here. I was very pleased to have this invitation to give this talk because myasthenia is really an area of neurology and especially of neuromuscular disease that has just changed incredibly. And the whole conversation around myasthenia that we have in the clinic with patients has really changed dramatically. And the opportunity I have today is to share with you some of the changes and some of the excitement around these changes in the field for those of you that might not be as aware. Let me just see. So I titled this talk, Setting the Bar for a Life Without Symptoms, a bit of a grandiose title, but it's actually reflecting how I see the change in the conversation for myasthenia. And so I'm hopeful that I'll present some concepts today, and then we'll have a engaged discussion. And I think Marissa may have mentioned that you're certainly welcome to put in comments or questions in the chat, and I'll make sure that we leave enough time before the end of my allotted time to be able to address some of them. But ideally, if I was giving this talk, I'd want to be in person so I could kind of have it more be dynamic and interactive, but we're going to be using the chat instead. So what I hope to do today is in 5 points to cover overall. We're going to start off with a very brief overview of myasthenia. I realize that some of you may have been tuning in to the talks yesterday and the subsequent one today, and so this has probably already been covered, so I'm going to spend very little time speaking about the disease. But for those of you who have not been tuned into the others, I'll give you some basis. As well, the history and what I call the rate of discovery, which is really remarkable in myasthenia, how much we've learned over such a recent short period of time. And then following that, the current treatment landscape. What kind of tools do we have to bear that generate all of this enthusiasm about potential outcomes? And really the bulk of what I want to talk about is changing the expectation. Of course, I can't see who I'm speaking with because of the format that we're using, but assuming that some of you have been dealing with myasthenia or myasthenic symptoms for a long time, what has changed, and where should your expectations be for how good you should feel or how effective the treatment should be? And then lastly, the fifth point kind of ties into that, because if you understand the role of being hopeful about these changes and the ones that are forthcoming, also how you cope with the disease, it most definitely affects your perception. Your perceptions most definitely affect your health and your outcomes. So it'll make a little bit more sense when we get to that, but those are the 5 points that I'm going to cover over probably about 35 minutes or so. So what I hope to leave you with when we're done here is four takeaway messages. So if I lose you along the way, perhaps you can just keep in mind these 4 things. Number 1, myasthenia gravis today is a very treatable condition. Very treatable condition. That means that we have more tools to bring to bear, more treatments to try and combinations to try than we have ever had in my years of practice. The second thing is the concept of minimal symptom expression. This is a fairly new concept, relatively new concept in the field, but essentially it means that your symptoms might not bother you. That is, they're so minimal that you might have them, but they're really not getting in your way. That is a very attainable treatment goal. And if you're not there now, perhaps the conversation with your treating physician, or if you are a treating physician, the conversation with your patient might be evolving to try different things, because it is a very attainable goal. The number of treatments that we have and the number of available drugs that we have has never been better than it is right now, and it's only going to get better still in the near future. And then, as I mentioned earlier, your perceptions of your health and your future are likely just as important as the medication. I know that sounds a little counterintuitive because everybody wants to feel better, but how you really see your future with myasthenia, there's an evolving body of literature, of research that really suggests that the attitude, the emotional state, where you're coming from, is as important as the medicine that is being used to treat you. So I don't think I have to tell this group, assuming most of you are from the patient community, how myasthenia affects you. It can affect you in many different ways. For some folks, it's just ocular eye findings, droopy eyelids, double vision. Others, it's speech or breathing or weakness in your arms and your legs, or perhaps your neck, and there's various combinations. The important thing to remember here is it is a very variable presentation. 2 people with the same diagnosis don't have the same problem necessarily. You can, but it's quite unique. In fact, since I've become more involved in the myasthenia patient care community, I understand the concept or the term snowflake disease, as in two snowflakes are not alike, neither are two patients with myasthenia. This is an important concept to start with, because as patients are different, so should their path to improvement be different. Obviously, if you don't have an ocular problem, you wouldn't expect the eyes or the ocular problem to improve. So you have to sort of set the bar with patients different, individualized, for their improvement. And we'll talk some about how we do that in the clinic. Now, myasthenia is, as you probably well know, an autoimmune disease. That means that the body is making an antibody, the immune system is making an antibody that it shouldn't make. It shouldn't make it because it's targeting something that is supposed to be present. That is the acetylcholine receptor, which resides on the muscle membrane. I don't know if my pointer shows up on the shared screen, but you can see where it's labeled acetylcholine receptors, and these little green dots are released from the nerve that's adjacent to the muscle. They literally float a very short distance to attach themselves to these receptors. If the acetylcholine, a neurotransmitter chemical, binds to these receptors, the muscle contracts. So anything that impairs either the release of the acetylcholine or the availability of the receptor to receive the acetylcholine, that's going to impair the function of the muscle, and that's going to cause weakness. Now, in the case of myasthenia, as in this lower right panel, these little blue Y-shaped features in the cartoon, they are the antibodies directed against the acetylcholine receptor. And because the antibody is binding the acetylcholine receptor, that receptor is not available to receive the acetylcholine. And as a result, that receptor is not functional. The muscle doesn't contract. That is why you get weak, because there isn't enough chemical binding to the receptor. So this is a disorder that we understand quite well. We understand why it happens in terms of the antibody being produced. We understand how it happens. And as we'll talk about, understand how to treat it. Now, what happens when that antibody binds the acetylcholine receptor is several things. Sometimes there's just a blocking of the antibody on the receptor. Other times there's an inactivation of the antibody by cross-linking. And thirdly, there's a way that you can trigger or stimulate the degeneration of that receptor. Probably all three of these mechanisms are operable at any one time, but they're all with the same common feature that the receptor is not working. It's a dysfunctional receptor. In the latter case, where the antibody-dependent complement is degrading the receptor, the recovery of that requires a new receptor to be synthesized and put into the membrane. On the other examples, there might be a way to remove the antibody. But regardless, the receptor is deficient, and that is the nature, that is what we call the pathophysiology of this disease. An unwanted antibody is binding a receptor that's supposed to be there and resulting in the muscle not working. Now, if you think about that, in any autoimmune disease, and there are many autoimmune diseases in neurology and in medicine, quite a few, where a different antibody is made. If you think about it, how can you address these issues? Well, the simple thing is to say we could immunomodulate. Basically, we could either reduce the production of the antibody so that it's not made so much. We could turn down the immune system. We could clear the antibody from the body. Like, for example, in plasmapheresis or plasma exchange, we're actually taking the antibody out. There's other drugs that do that as well, from not just plasma exchange. Or we could reduce the pathogenicity. That is, we could make the antibody less dangerous, inactivate, if you will, the antibody. And honestly, if you think about having an unwanted antibody and how would you treat that, I can't think of another mechanism. Either you reduce the production, you clear what's being produced, or you make the antibody less dangerous. And fortunately, these three main mechanisms of treatment, we have medications and therapies in each of these. That's a very fortunate situation, because not only do we understand what happened, but we have multiple ways to treat it based upon which medication or therapy you're going to use from these various categories. Now, there is one therapy that is very common in treating myasthenic patients, which does not modify the immune system, and that is pyridostigmine or Mestinon. Pyridostigmine, or Mestinon is the trade name, that acts by enhancing the amount of acetylcholine that the receptors see. By slowing down the degradation of the acetylcholine, more is around for longer. So it can be very effective for patients when they're not terribly weak, or to keep symptoms in check, but it is not regulating the immune system. It's actually affecting the degeneration of the acetylcholine. So most all of the therapies for myasthenia fall into the first category of immunomodulation, and pyridostigmine or Mestinon is the only one that falls into this other category. Now, as you probably well know, pyridostigmine can be very easy to take, can be very effective, but it's not generally as strong or as powerful a treatment as some of the immunomodulating therapies. Sometimes it's all you need, but on other situations, we need to pair it up with one or more of the immunomodulating therapies. Now, this is a very busy slide, and it's actually good busy. I don't intend for you to absorb all of this, but this is a slide, and I apologize, I forgot where I found this. It's from the literature, and I wanted to cite the reference, but I couldn't remember where I found it from. So apologies if you know and I'm not citing them, but it gives you an idea of what's happened in the field. And this is only to 2019, so it's already dated, because a lot has happened between 2019 and 2024. But the green arrows, as you can see, pointing downward, these are milestone discoveries in our understanding of myasthenia. Whereas the blue arrows that are pointing up are drugs. The drugs like the ones that you're familiar with, eculizumab, ravulizumab, mycophenolate, IVIG, pyridostigmine, azathioprine. And what you can see, and you'll see in the subsequent slide, is the rate of the discovery, the rate of introducing new ideas, especially new mechanisms and new drugs to the field, is picking up. If this graph were to continue out to the right into 2024, it would be even busier, because the number of discoveries is quite large. I can tell you from treating a variety of neurodegenerative diseases, I wish we had this in other fields. In neurology, I'm not aware that we have this level of understanding, of discovery, of new drugs in such a confined period of time. We certainly don't have it for disorders like Parkinson's and ALS and Huntington's disease. We don't have it for a lot of other neuromuscular conditions as well. So in some ways, myasthenia starts out, even before the most recent advances, a little ahead of the curve, because our rate of understanding, our level of understanding is so good, and the pace of discovery has been so favorable. A simpler graph to understand is this, which is just really the drugs, to give you an idea. And you can see between 2022 and 2024, there have been an heightened discovery. And we're not done. I mean, I'm aware of medications that are in the pipeline right now that are going to make the graph, as it extends to the right, even be more crowded, still in early clinical trials or in planning stages. And then I think we haven't really taken into account the possibility of the combinations of these therapies as being a line of defense. But that too is an area ripe for future investigation. So many, many tools. Many of you, I'm sure, recognize the drugs that you may have been exposed to on this list, but we have more or less, this is a menu of the medications we use. This is not an exhaustive list. I'm sure that there's a few things that you may have experienced, that you may have been prescribed that are not on this list. These are the ones that we used more than not. Some of these are more recent. Some of these have been around for quite some time. But there are quite a few, as we say, bullets in the gun, meaning to say there are quite a few avenues of possible treatment to evaluate for myasthenia. What's different, though, and what's changed recently, is the most recent medications that have been added are not just new medications. They represent new mechanisms of treatment. They represent ways of modulating the immune system that we haven't done before with the earlier medicines. So now, not only do we have new medications, we have new mechanisms. And as I mentioned, more on the horizon. When I think about medications to treat myasthenia, new medications as well as old medications, I think of them in groups. And that grouping is dependent upon how fast they act. For example, pyridostigmine, mestinon, as you may know, acts within minutes. You often can see or feel an effect within, say, 30 minutes or so. Whereas plasma exchange or gamma globulin, that may take 1 week, 2 weeks. Occasionally somebody says it's shorter, but I don't really look for the optimal effect until perhaps 2 to 4 weeks after the end of the infusion, because sometimes it takes a while for the changes to the immune system to reflect changes in the disease outcome. Prednisone, this is a little variable, but it can affect its onset of effect can be quite short, as in a day, 2 days, a week, or it can extend into several weeks, but it's on the shorter ending. And that means that most all of the other drugs that are on this slide, other than the ones that I just mentioned, they take months, weeks to months to act. So when we start somebody on a medication, say azathioprine or Imuran, I'm not actually looking for a benefit of that drug for perhaps 6 months. That's an important consideration when you're treating patients, because if I need to get somebody out of trouble, so to speak, as in I think that their symptoms are progressing rapidly, some of these drugs that take months to work are not really going to be the benefit. Now, the interesting part and the fortunate part of this is the newer drugs that have come on the field. Those that I mentioned are both new mechanisms and new drugs. They are falling in this early phase of treatment here. They're falling in between or around when the plasma exchange IVIG forms, and sometimes even sooner. I'll show you some data shortly that show the benefit of some of the new drugs, even within the first treatment course, which is within the first of 4 weekly injections. So we have another very fortunate occurrence, which is new drug, new mechanism, and now earlier acting, which is quite important. I don't think I have to tell a group of mostly patients to say, how does this affect your life? I'm sure that you can tell me how it affects your life, but there have been a number of research studies looking at the impact of myasthenia on life, and it's clear that these are survey data that came from this article from 2023 that suggests that there are clearly emotional impacts of this disease, second and apart from physical impacts and apart from the social impact. And then as the physical impacts impairs daily activities of daily living, or ADLs, you can see here, and perhaps your own experience varies a bit in this, but I don't think it would be hard to come up with a list. If this was an open mic and everybody could volunteer, I think we would reproduce this survey. This was exactly what I see. If it's not an effect at work, not being able to go to work or not being able to do your job regularly, it's affecting your emotional health, your social health, and we're going to talk more about this. But the reason I show this is to give everybody a solid foundation of the variety of things that can be affected by or impacted by the disease. So you might think, how in the world, with so much variability in how it affects people, how can you measure that? And that's really important. And I think measuring these problems, what we have done for years, and I say myself, what I have done for years, is try to manage these episodes of exacerbation. For years that I have been taking care of patients with myasthenia, the goal was to make the flare-ups further and fewer between, and to make the rest of the time tolerable, to figure out which of these were most impacted, address that, and manage the episodes when it flares up. But things have changed now, and that's one of the takeaway messages from today. No longer do I look to just manage episodes of exacerbation. We have changed from this, on this continuum, to this. I want there to be no symptoms. I want the patient to be symptom-free. And why did that become realistic? Because the data show that these new medications can frequently bring a person to that stage. And in fact, many times the older medications can do this the same. But what had happened, I think, over time, and this is not a fault, this was just the sign of the times for treatment, or the reflecting our ability to use the available tools. People would say, I'm okay. I'm not great. I'm not like I used to be, but I'm getting by. And getting by was the standard of treatment for a lot. That is, I can get by, meaning I can work, I can go to work, I can function in my family. And yes, I don't do some of the activities I used to do, but I'm okay. I personally have changed the dialogue in the clinic with my patients to the best that I can. I try to get them to say, I'm not going for okay. I'm going for, I don't have symptoms right now. And so being symptom-free might always have been on the wish list for, but it is quite attainable now, more than it has ever been before. And that's really the gist of where I'm coming from with these comments. Now, the way we measure outcome, there's a variety of ways, but one of the most common ways that most of you are probably familiar with is a questionnaire called the MG, Myasthenia Gravis, Activities of Daily Living Scale, the MGADL scale. It's a simple questionnaire. I'm sure many of you have been asked these questions if you're patients. It takes just minutes in the clinic, and I use it now more than I ever have before. Before, I just used to ask them about the thing that was bothering them in the past and find out if that was still an issue, if there anything new, and I would go on. This is a score that's kind of captures some of the more common problems. It doesn't capture everything that a myasthenic patient might have a concern about, but it does capture. And I want to just take a minute to look at this score, because the newer drugs that were approved, they were approved largely based on improvements in this scale. So if I say to you that there was a 2-point improvement or a 5-point improvement, I just want to show you what that means. So there are 8 different questions that you can ask here about talking, another question about chewing, another about swallowing, breathing, brushing your teeth or hair, using your arms up above your head, rising from a chair, double vision or ptosis or eyelids. And you can score from either a 0 to a 3 based on your severity of symptom in these different categories. So, for example, if it's in swallowing, you could get a score of 1 if you say, every once in a while, if I'm not careful, I have choking, versus frequent choking, and you have to change your diet, versus you needing a PEG tube or a gastrostomy tube, which lessens or eliminates the risk of choking. But the difference between rarely choking and needing a gastrostomy to swallow is a difference of 2 points on this scale. And likewise, if you're talking about double vision, from having constant double vision to having just occasional periodic double vision, that's 2 points. So the motion of 1 point versus another point, they're not equally weighted. It takes perhaps more to get from a 2 to a 3 than it does to get from a 1 to a 2. But I want you to appreciate the magnitude of the symptom that changes with a score of just 1, 2, or 3. Now, this concept of minimal symptom expression or minimal manifestations is a similar concept, meaning you don't have problematic symptoms. That means you only have a score of 0, 1, or 2 on this scale. So if the only thing you have is one of these, that you need a little bit of extra rest period when you're washing your hair, but everything else is fine, that would be considered minimal manifestations. I actually go for the 0 because I'd like there to be no symptoms, but in the literature, it's a very low score. The highest score you can get here would be 8 times 3 or 24, which is a person who's quite disabled from these myasthenic symptoms. Now, these are some data that came from the trial where efgartigimod or Vyvgart was studied. The trial was called the ADAPT trial, and many of you might be familiar with this. And this is called a Christmas tree plot because it's a probability. So they're saying the improvement in the ADL score was 9. That's a lot of points. You could see how much that might benefit a person. 9 improvement points in 14% of the treated patients. 8, if the improvement was at 8, it was 20%. And you could see likewise improvement of 7 was cumulatively 27%. So there was a significant number of patients that achieved a very significant improvement in the MG-ADL score. Now, the other point to take away from this is this occurred in the first treatment cycle. That means within the first 4 weeks of treatment, there were 14%, or let's say 27% of the patients improved 7 points on that ADL score. That is not trivial. There's more data that followed this, but this effect held up, and it actually gets better as you go forward. But suffice to say, the power of this type of treatment, it's not limited to efgartigimod, but it's certainly included, is quite significant. And overall in the trial, 40% of the patients that were receiving that medication achieved a minimal symptom expression, which was just that 0, 1, or 2 on the ADL score. So, it got my attention, to tell you the truth. And it's been my experience as well in the clinic that efgartigimod, as well as some of the other newer drugs, can actually bring a patient to minimal symptom expression who might not have experienced that anywhere sooner in their course. These are data that came from a different trial. This is a trial that was testing eculizumab, which is Soliris, the trade name. And what it shows is the number of percentage of patients in the different parts of the trial that actually reached minimal symptom expression. So at the end of week 1, 5% of the treated patients reached a minimal symptom expression. None of the placebos did. At the end of week 4, about 13%. And as you can see, it went up from there. Now, when they did the open label study where they basically gave everybody the drug that wanted it, including the prior placebo patients, the rate of approximately 22% with minimal symptoms was achieved, even if initially these patients here got placebo in the first part. When they were switched to the real drug after 6 months, then they attained that same percentage of minimal symptom expression. I can't say that I'm knowledgeable about every single trial result that came out prior to this, but I had not been familiar with results as significant as this and the one I showed you earlier, where this number of patients with an increasing number reaching minimal symptom expression. So this is a different type of study that was published last year, Dr. Uzawa, which showed the benefits of early fast-acting treatment, that is the gamma globulin and prednisone. If you treat patients early and then follow them over time, they are managed better with lesser treatment, and they reached minimal symptom expression sometime as high as 70%, as you can see here. These MM5 means these patients were maintained on just 5 milligrams of prednisone, a low dose, and they were treated early, opposed to patients that were not treated early. Their ability to reach the status of minimal symptom expression was much less. So this is just another report that suggests that treating patients is very important. Treating them early and aggressively with fast-acting drugs is important, and minimal manifestation or minimal symptom expression is attainable. So let's talk a little bit. I'm going to change gears just a bit away from the data, the hard data of these trials, to talk about another aspect of the disability, which is highly treatable. Before I get to that, though, I want to talk about what you already know better than I do. Myasthenia can result in an altered lifestyle. I don't think I need to expand on that. I think you probably are well aware of that. But if you take that reality that many of you experience and you add to the fact that this disease occurred spontaneously, that is, you were minding your own business and all of a sudden you were diagnosed with this after your symptoms came on. You didn't do anything with regard to lifestyle or diet or so that created this. This was something that you did not see coming. You also realize very much that this is a lifelong condition. And the biggest issue, which I consider to be one of the biggest disabilities, is that this is an unpredictable disease. And in my experience in dealing with many patients, it's the unpredictability of this disease that can be quite, it can induce quite a bit of fear. The uncertainty of the disease, not knowing if the vacation that you planned and had paid for and you're about to go on is actually going to happen, because if you have a myasthenic flare-up before, or perhaps a big family event, a wedding or so, and you are all set to go, and either because of the stress of the event or perhaps because of no specific trigger, you get a myasthenic flare. When you add these features together, the ongoing disability, the fact that it occurred spontaneously, it's lifelong, it's very unpredictable. My experience is when you add these together, the most common resulting disability, which is actually worse than some of the physical disabilities that you might experience, is fear. You're afraid for a very good reason. You're afraid about what could come next. I can't predict that I'm going to be healthy when I otherwise should feel healthy. I can't do anything about why this occurred. I can't change my lifestyle. And that fear, in my experience with many patients, has been perhaps more disabling than many of the things that I'm treating in them physically. So let's talk for a moment about fear, because the only treatment for fear that I have ever been aware of, and if you're feeling hopeful, you're less afraid. So hope, in an odd sort of a stretch, hope can actually be an important part of a therapy plan for a patient. And I will tell you, which I wasn't always able to say, as a myasthenic patient, you have more to be hopeful for today with what's going on in the field than ever before, with the new mechanisms, the new drugs, many new ways to feel hopeful to address the fear. Now, hope is a funny concept, because I know many people might feel, oh, hope is, it's just in my head. It's nothing I have to go to the doctor for. Hope is actually a resource for many patients, and it influences your ability to cope with any stressful situation. If you're a hopeful, optimistic kind of person, you're generally less stressed. The reason for that is when stress comes your way, you're finding an angle around it. You're finding the silver lining, so to speak. There's a lot of literature about this. There's a lot of literature about the role of hope as a therapeutic modality. And hope in some of these studies has resulted in better quality of life than just the medication alone, for sure. So the frame of mind, or as we say in the clinic, where your head is as, or perhaps more important sometimes than where your rest of your body is. So some of the literature that I'll show you comes from the patient literature as to what patients think about being hopeful. And their hope has been defined as the possibility of a future that's better than an uncertain and difficult present. Now, this wasn't in the context of myasthenia. This article was about chronic illness. And it's very applicable to myasthenia, because the uncertain future is some of the reason why many patients are not so hopeful, or at least feeling very fearful. Otherwise would say hope is an effective strategy to help people cope. And coping is really important. And the most important hopeful takeaway from all of this is that doing nothing is not an option. If you are sitting with a lot of myasthenic symptoms that you have just come to accept and decide that that is your lot, and you don't necessarily have to keep navigating for new treatments, I don't necessarily agree with that. I think that doing nothing is really not an option when there is so much that can be done, and hopefully might result in better outcomes. So I think we talked about this one here. So let's talk just a few moments about coping, because coping and hope are very, very intertwined. So there's different kinds of coping strategies that patients use, not just myasthenic patients, but patients that are dealing with any kind of adversity. So there's something called emotion-focused coping. That's a person who basically is like appraises the situation, doesn't think much can be done, and just gets by and says, all right, this is the hand that I was dealt. I'm just going to get by. Maybe wishful thinking, maybe it'll get better, maybe it won't, but I'm not going to let this get in front of me. I'm just going to be okay with the accommodations that I have to make in my lifestyle. It works for many people. There's actually a literature, as you can see, this is an older article, but the emotion-focused coping is what some people's goal is. Just accept what you have and go by. The other kind of coping is what's called problem-focused coping. I actually like this one. I like it more than emotion-focused because this is a person who doesn't necessarily want to accept, but they're not rolling over. They're not angry. They're like, bring it on. What else do you have? There's got to be something else. This is somebody who says, this is a problem. We're going to focus on this problem until we find a solution or a partial solution. So they function to create a change in the treatment plan, in their interaction, in their family dynamic to meet the conditions. So they're not necessarily accepting the way that an emotion-focused coping person would, but a problem-focused coping person is looking for a different path forward. Either of these work. Either of these will help you get through a day. One of them may result in less symptoms. There's an abundance of literature. I don't have time today to go through many of these articles, but if this is something of interest to you, I can send you references or it'll be on this slide. And there's even more current references looking for different mechanisms of coping, different mind, body, and psychological meditation states that facilitate your ability to cope and as a result, heal. This is an actual interesting study that was looking at the physiological effects of mindfulness meditation on your immune system. So this was a study that evaluated patients when they were trained in mindfulness meditation, and they actually measured different markers of cell-mediated immunity, as you can see, biological aging and inflammation, and they found that the markers went in the right direction. That is, the mindfulness meditation in these patients actually changed their physiology. With respect to an autoimmune disease, some of these markers that were affected would be considered to be very constructive. Certainly, if cell-mediated immunity was abated, if inflammation was decreased, I could imagine that the pathogenicity of the autoimmune disease might also benefit. It was not studied specifically in myasthenia, but I thought it was a relevant reference to have. This is, again, quite a busy slide, but if you just focus in on this, you can see, again, different stressors, different the different studies that looked at these various different markers. We don't have time to go through all of them, but I can tell you that some of these are very relevant to autoimmunity and very relevant to inflammation. And this was a study on the mindfulness meditation favorably impacting those markers. A different study looked at the combination of hope and coping, and they actually looked at three variables, this hope index, a coping scale, and a quality of life measure. They looked at three variables in 90 subjects. Again, these patients had myasthenia. This was a myasthenia-specific study, and they found that there's a very significant relationship on your ability to be hopeful and your ability to cope with the disease. And hope and quality of life were very intertwined, very correlated, not a surprise, and quality of life and coping was very correlated. The thing that I thought was the most striking from this publication was that the attitude, the hopeful attitude that a person adopted was graded by patients to be significantly more important than their reported quality of life. That is, they felt better by just being hopeful without having the other indices on the quality of life scale. So the ability to find a coping strategy that works, the ability to understand what it is to be hopeful in a disease with so much current discovery, is very important to the ultimate outcome of the disease. A different study still, effects on the quality of life of a myasthenic patient. They thought the things that affected the quality of life more than the disease itself was a change in the caregiver, a change in your job, or if a patient were depressed. And the physical limitations were not the most significant factor affecting the quality of life. It was these other factors, or perhaps the sense of hopefulness. Many different things beyond the scope of this webinar that we can talk about as far as ways to affect your emotional health. That probably is its own webinar of the future. These are what we have behavioral health specialists in the clinic with us full time, and these are the kind of things that they're addressing with our patients to try to get their head in another place. So just to wrap this up before I open it up for questions from the chat, I hope I've been able to show you that we've evolved our thinking a little bit. We've evolved from managing symptoms to kind of putting them in check to actually pushing patients towards being symptom-free. My conversation with patients initially when I first meet them is very different today than it was 10 years ago. I tell them my goal is to have you be symptom-free. So when I ask you how you're doing, okay isn't really helpful. I want to know, like I was before I was sick, or this is what's still wrong, because the bar has been raised for that treatment. And I hope I've been able to show you some of that. The takeaway messages: myasthenia is very, very treatable. Minimal symptom expression is most certainly attainable. There are many different available drugs, more than ever before. And your perceptions of your health and your future can be as important, and perhaps in some cases more important, than the actual medication. So I'd like to stop there, and I certainly welcome any comments from the chat that you might have already put in or have now, and I look forward to answering. Thank you.
Thank you so much, Dr. Rosenfeld. That was an excellent presentation, very easy to understand and really helpful information. So thank you very, very much. We do have a few questions in the chat. So let me go ahead and get those. The first thing we have, sorry, I'm just pulling them up here. Do you think there is a difference in effectiveness of SCIG versus IVIG?
Well, I don't think there's a difference. In fairness, I don't have very many patients on subcutaneous gamma globulin. And for those of you who don't know what we're talking about, the intravenous gamma globulin, several drugs in addition, but intravenous gamma globulin can be given intravenously through the vein, or it can be injected under the skin. The data would suggest it's at least as good as the intravenous. I don't have enough patients to tell you my own experience. I have just a few. They're doing okay. They're doing well, but I just met with somebody yesterday, and I was suggesting it wasn't gamma globulin, it was another drug, and they said, no, I like the people at the infusion center too much. I don't want to switch, so I'll never get a chance to figure that out. So I guess the answer is I think it's likely as effective as the intravenous, but I don't have a huge denominator to tell you. The data in the literature would suggest it's as effective.
Okay, great. Next question: in AChR positive patients, rituximab works if used early. If B cells are 0 after induction, why is there improvement with subsequent doses?
Because B cells are not 0. You're right about the sense. So rituximab has been very effective. I have used it at different stages of the disease. And my impression is, although we don't always measure this, that the B cells do not go to 0. You're basically impeding the production of those B cells, but we don't completely knock them out. And remember, the immune system is doing what the immune system thinks is right, and that is churning out that antibody. So one thought is, if you deplete the antibody, the immune system has a choice, if you will, doesn't have a brain, but it has a choice. The choice is make the antibody again that you just depleted, or switch priorities and go on to something else. Sometimes it replaces that antibody. So the subsequent doses of Rituxan are to further deplete the B cell population, but I do not think it's zero when we start out.
Great, thank you. Another question, somebody shared that they have MG and Parkinson's and have head drop. Is there any neck brace for just that symptom?
There sure are. There are several neck braces for that symptom, and I would encourage you to find the one that's most effective. If the head drop is due from the myasthenia, it's a tricky situation because you can get similar overlapping symptoms. But if the head drop were from the myasthenia, I certainly would recommend the head brace, but I would also recommend trying therapies to address that, because that should be something that we should be able to make somewhat better. If the head drop is from the Parkinson or perhaps a little bit of both, then yes, it might require physical support. There are a variety of neck braces. They differ in what they're made of, how much air circulates around your neck. There's one that's just open to the air. It's got padded wire frame, so it kind of sits as like a foam covered wire that sits on your clavicle and up under your chin, but there's no constriction. There's others that are more constricting. It just depends upon your preference, but we prescribe quite a few different types of neck braces to suit different needs. But yes, I suspect there is one for you.
Another person shared that they wanted to know, how do you deal with law enforcement that maybe because of the myasthenia gravis think that they are drunk or impaired in some way? Have you ever come across that or had patients ask you about that?
I have had patients ask me about it. I haven't come across it, but I guess it would depend on the scenario. So if you're driving, for example, and you come out of the car and the law enforcement officer sees that your eyes are mostly closed because you have ptosis and you have a flare-up, I mean, it is a reasonable thing to say, should you have been driving because it flared up. So their point is well taken. My experience is that patients are usually able to say, I have a medical condition called myasthenia gravis. Some of my patients choose to wear a medic alert bracelet, which makes them aware. But I think you have to judge yourself. If somebody from law enforcement is concerned about your symptoms, either because you're not walking well or you're not speaking well, or your eyes are either not aligned or you have ptosis, I suspect you're coming to attention from them because probably you're driving, or perhaps usually they don't stop you if you're walking, but it would depend on the circumstance. But my experience has been, for those patients that are concerned by it, they wear a medic alert bracelet. The other ones would be just more aligned to tell them verbally what's going on.
Yeah. MDA, we actually put together a emergency alert card that's available on our website specifically for myasthenia gravis, and you can always carry that with you and fill it out with specific information. It's always good to have that in case of an emergency. How about another one that came in? Are there any dietary recommendations for myasthenia gravis?
That's a good question. We tried different things. I mean, there are certainly what's called the so-called anti-inflammatory diets. They're healthy diets. Yes, the answer is there are some diets out there. I'm not aware of any systematic study that shows one to be that much better or more effective than the other. We have a full-time dietitian on our team who talks to patients about this very issue. I don't endorse one particular diet for my patients. I think it goes without saying that a healthier diet is generally better in overall. Better in the sense that if you're not eating well, if you're eating, say, fried food, fast food all the time, you generally don't feel as well. Your energy level is perhaps more impaired. These are things that you can do something about if you eat a healthy diet and you balance, the the vices that might make it not a healthy diet, you balance them with healthy choices, you'll feel better. And as a result of feeling better, you'll do better. And a lot of myasthenia management on a day-to-day basis, I'm imagining you would think, is energy conservation or what you can do to help yourself. And so I think healthy diet in general, perhaps if you were going to try any specialty diet, although there is no evidence to prove, it would be some of these specialty diets for the immune system and inflammation.
That makes sense. We actually will be doing a nutrition webinar at the end of July.
Oh, great.
So that could be helpful for some folks as well. Let's see, another question came in, and you had kind of touched on this at the end of your presentation about alternative or complementary therapies. I saw you had up there like acupuncture. So are there any alternative or complementary therapies that may be helpful? And if there's anything you can do to kind of expound on why they might be helpful?
Well, I mean, if I was asking the question instead of answering it, and I asked you all in the patient world, what are the things that you think trigger your symptoms? I would imagine some of the answers would be anxiety. Stress and anxiety would be up there. That's what I hear the most. It could be family stress, it could be work stress, it could be just self-induced personal stress. It's not selective. Another answer would be illness, often triggers the symptoms. But with regard to things that you can do with alternative therapies, you have to ask yourself, what triggers me? What makes me feel worse? And if the answer is anxiety and stress, then there's a large number of these alternative therapies that address that, whether it's meditation, yoga, mindfulness, sometimes acupuncture. The list is longer than that. I would say it's most definitely to your benefit to explore that, because if you have the insight into what triggers you, but not the insight into how to address that particular trigger, you're cutting yourself short. You've done the hard part to address the trigger. So my suggestion would be find the modality that helps you. There isn't one for all. I have a patient that really enjoys acupuncture. Another really enjoys massage, and several of them do yoga and others meditation. So I would not say that there's one thing, but I do certainly think that is worth exploring, especially if you feel that your triggers are anxiety and stress.
Yeah. No, that's a great way to think about it, thinking about your triggers. Another question came in, why is fatigue not rated on ADL? There's a big difference in needing to be in bed to feeling like walking in quicksand, to having energy to do things.
I would have asked that question if I was sitting where you were. I've asked that question. I think it should be. Fatigue is a very subjective topic. So it's a common problem. The way we call it in the clinic is not necessarily fatigue. We say it's exercise intolerance, meaning you can start out, but you tucker out really quickly. And so you are, in fact, fatigued, but you just didn't tolerate the same exercise. So I think a question about exercise intolerance, i.e. fatigability, would be a benefit to the ADL. I wasn't involved with the creation of the MG-ADL score, but I think, kind of reading the room, as it were, amongst my colleagues, I think part of the reason it didn't make the cut is because the concept of fatigue differs so much between patients. Whereas if I say to you, do your eyes close down all the time, some of the time, or never, that's objective. If I say to you, do you have trouble getting up from a seat, meaning you have to use your hands all the time, some of the time, or never, those are more objective features. If I say, do you feel fatigued when you walk your usual distances, what does that mean? And so I totally get the relevance. I totally would like to know that. There are separate fatigue scales, fatigability scales, and they have been entertained in other clinical trials. But I wasn't there I wasn't at the table when they developed the ADL, but I suspect that was the reason it wasn't included.
Thank you. Another question came in. Can you develop an allergic reaction 10 weeks after using a daily injection like Zilbrysco? I'm not sure I said that right. Or
I'm not sure about that. I guess you can always develop an allergic reaction. It is a little bit odd 10 weeks in, but the immune system is quirky, and I would need to know a little bit more about the clinical situation that's coming from. And obviously I can't do that on this webinar, but I don't know how to answer that because I don't know enough about what it was that was experienced and what other kind of medical issues could play into that. So I'm sorry, but I can't really give you a very good answer for that, except it's a little long.
Yeah. No, thank you. We know sometimes we can't dive into real specifics here. Another question says, I understand you are targeting a 0 symptom, but if you come across a patient who has tolerated rituximab and had tremendously gotten all other symptoms down and manageable, but still has diploia and ptosis once in a while, would you still recommend changing the treatment to something else? Like maybe that's a real issue that I see in the clinic. And I guess if you were my patient, I would say, how does your life change by having residual ptosis and diplopia? How does it change? Are you not doing anything that you would do? Did you stop driving because of the diplopia? Did you change your job? And if I hear anything that you otherwise would be doing different, then I think, yeah, maybe it's worth it to try something else. I've had really good result in some patients with rituximab, just like you described, and it has knocked it down. But if it's residual and you're still dealing with it, and that dealing with it means you're not doing something in your life that you might otherwise do, perhaps I would suggest that it might be time to try something different. You can always go back. Hopefully it would work the same, should work the same going back, but I'm more optimistic about that. So unless the patient said, no, it's not really bothering me, or it's not changing, I wouldn't be doing anything different if I didn't have this, then perhaps not. Great. Well, we just have time for about one more question here. This is a broad question, and you did cover a lot of it in your presentation, but perhaps a summary of what can we do or what can I do to optimize my quality of life?
It's a very general question.
It is. Yeah.
I guess it depends a little bit about where it's off right now and where your symptoms are. So there's many ways that you can go with that. But I can give you a kind of a global answer to a global question. If you're not where you want to be at, change the conversation with your doctor. The conversation with your doctor should not be, I'm getting by. The conversation with your doctor should be, I'm not where I want to be. And if your quality of life is impacted by your myasthenia, and there's room to try other things, and you're interested in that, the first step the first step would be to change your attitude from perhaps what might have been the emotion-based coper that I mentioned in my slide to the problem-based coper. Now you've got an issue that you want to address. And the second solution is change the dialogue with your neurologist and say, can we consider other modes of therapy to see if we can get this better, assuming that the quality of life is impacted by the myasthenia score, by the symptoms. Yeah. I would do that. I wish I could answer you more specifically, but I need to know what's impacting the quality of your life. Yeah.
Sure. No, I think that's a great summary and a really hopeful presentation in terms of you don't have to just be okay. You can be better than okay.
Right.
So
before we end off, I just want to make one comment. This talk that I've just given you is kind of a new and a different one for me. Most of the time I get to speak on myasthenia, I'm speaking about either a particular mechanism or drug or something not quite as patient-focused in terms of lifestyle and things like this. And I'm curious, without being able to read the room and look at your faces, about how this came across. So it would be very helpful to me if you would, at some point before the end of these two talks, just jot down what you thought about whether this was useful information for you, because it's likely that I might be asked to do something like this in the future, or I might volunteer to do this in the future. And I'm curious to know what rings true for you, or was this not informative enough and I would need to change direction if I was going to address this topic again. So I would just appreciate it if you have a moment to jot in the chat some feedback.
Yeah, absolutely. And thank you. I think it's wonderful that you want that feedback. So we do have a survey that will pop up at the end, where you can definitely, people can enter their comments, or you're welcome to also share your comments in the chat. But I want to thank you, Dr. Rosenfeld, for your time and for sharing your expertise today with us. Yes, just thank you for joining us. It really was great.
My pleasure. And thank you all for tuning in.